4 million Americans are walking around with this disease, and most of them have no idea. I don't need a lip biopsy or an ANA panel to suspect you. I don't need a Schummer strip pressed against your lower eyelid or a cyanometry tube measuring every drop of saliva your body can produce. I can spot Sjogren's syndrome from across the room. And today I am going to show you exactly how I do it, sign by sign, so that you can look in the mirror and ask yourself the question that your doctor may never have thought to ask you. Because here is what nobody tells you about Sjogren's syndrome. The average patient waits nearly 3 years from the moment their first symptoms appear to the day someone finally puts the right name on what is happening to them. 3 years of being told it is allergies, or stress, or getting older, or just needing more sleep. 3 years of damage quietly accumulating while the real answer was hiding in plain sight the entire time. If that sentence just landed for you, if something in what I've described so far sounds familiar, I've put together a symptom map that shows exactly how this condition progresses, what shows up at each stage, and where the standard tests are most likely to miss it. Type symptom map in the comments right now and I'll send it to you directly. Because what I'm about to show you next is why that map matters more than most people realize, and why the stage you're in changes everything about what happens next. Sjogren's syndrome, what does that mean? It means your immune system has declared war on the very glands that keep you moist. Your own white blood cells, the soldiers that are supposed to protect you, infiltrate the glands that make tears, saliva, and moisture throughout your entire body, and they destroy them from the inside out. The medical community calls this lymphocytic infiltration of the exocrine glands. What that means in plain language is that your body's defense force has confused its own moisture-producing factories for the enemy, and it is burning them down one at a time. When those glands go quiet, the damage spreads far beyond dry eyes and dry mouth. Without saliva washing your teeth clean around the clock, the bacteria that cause decay run completely unchecked, and they attack in a pattern unlike anything a regular cavity looks like. Without tears keeping your corneas hydrated and protected, the surface of your eye slowly breaks down, sometimes developing ulcers that can scar your vision permanently. Without moisture lining your airways, a chronic dry cough takes hold that no cough drop, no allergy medication, and no round of antibiotics will ever fully silence. The inflammation does not stay local. It travels. It attacks the nerves and produces tingling, numbness, and burning in the hands and feet. It invades the kidneys. It stiffens the lungs. It inflames the blood vessels. And it raises the risk of a specific type of blood cancer called non-Hodgkin lymphoma to levels that should make every doctor who sees this patient pay close attention, because 6% of people with systemic Sjogren's will develop it. And then there is the fatigue. The fatigue of Sjogren's syndrome is not the tiredness that a good night of sleep fixes. It is a bone-deep exhaustion that sits underneath everything the patient does, coloring every hour of every day, making ordinary tasks feel like they are being completed while moving through wet concrete. Research published in scientific journals confirms that the majority of Sjogren's patients describe this fatigue as one of their most disabling symptoms, and it often has nothing to do with how well or how poorly they slept the night before. It is the fatigue of a body under continuous, low-grade immune assault, and it looks different from ordinary tiredness when you know what to watch for. After years of studying this disease, I can spot the clues before the labs ever come back. Let me show you exactly how. Let's start with the easiest one. Take a look at the eyes. Healthy eyes are moist, white, and quietly comfortable. They don't demand your attention. They just work. The eyes of someone with Sjogren's tell a completely different story, and they tell it loudly once you know what to look for. Look for persistent redness, not the redness of a single bad night of sleep or a one-time allergy attack, but a chronic low-grade redness that never fully clears regardless of how many artificial teardrops go in. The white of the eye looks perpetually irritated, slightly inflamed, and raw even on good days. But the redness alone is not the whole story. Watch the blink rate. Healthy people blink somewhere between 10 and 20 times per minute, and most of that blinking happens without any conscious awareness at all. People with Sjogren's blink more frequently, and when you watch carefully you will notice a quality to the blink that is different. It is effortful. It is deliberate. Some patients do a slow, exaggerated blink that looks almost like they are trying to manually redistribute whatever thin film of moisture remains across their cornea, because that is exactly what they are doing. That excessive, deliberate blinking is not a nervous habit, and it is not a personality quirk. It is the body's desperate attempt to compensate for a tear film that evaporates faster than the lacrimal gland can replace it. People with Sjogrens describe the sensation as sandpaper moving behind their eyelids every time they blink. They describe it as gravel. They describe waking up in the morning and being unable to open their eyes immediately because the lids have temporarily adhered to the dry surface of the eye overnight. You can see the result from across the room. The eyes look tired, red, and raw even when the person just woke up from a full night of sleep. Now look at the face, specifically the jawline. This is the sign that surprises people the most when I point it out, because it hides in plain sight and most people mistake it for simple weight gain or a change in facial structure that comes with age. In healthy adults, the jaw angles smoothly into the neck. The transition from face to neck is clean and defined. In Sjogren's patients, look for a subtle but real fullness or puffiness that sits just below the ears and along the jawline where the parotid glands live. The parotid glands are the largest of the three major salivary glands, and they sit precisely in that space just in front of and slightly below each ear. Recurrent parotid gland swelling happens in between 22 and 66% of Sjogren's patients at some point during the course of their disease. The number that range covers reflects how variable it is. Some patients have obvious, dramatic swelling that makes their face look round and full on both sides simultaneously. Others have a subtle eversion that waxes and wanes over weeks or months, appearing more pronounced after meals when the gland tries to produce saliva it no longer has the capacity to generate efficiently. Some patients notice the swelling gets worse with stress or illness, then partially subsides. That fluctuating quality is itself a clue, because a mass that stays completely fixed and never changes size is a different kind of problem entirely. The Sjogren's parotid swelling moves with the patient's disease activity. When you see that bilateral soft fullness along the jaw in a woman between the ages of 40 and 60 who also looks chronically fatigued, you are already more than halfway to a diagnosis before she has said a single word about her symptoms. Focus next on the lips. This is one I watch closely from the moment a patient walks through the door. Healthy lips have a smooth, supple, clearly defined edge where the skin of the face transitions into the colored lip itself. That border is crisp. The surface of the lip is plump, moist-looking, and resilient. In Sjogren's patients, that transition zone becomes a problem, and it announces itself visually in several ways. The first thing to look for is cracking at the corners of the mouth. That raw, split, sometimes crusted irritation that sits right at the junction where the upper lip meets the lower lip at each side is called angular cheilitis, and it is a classic and highly recognizable finding in Sjogren's. It looks similar to what some people call cold sores, and patients are frequently told that is exactly what it is and handed antiviral medication that never fully resolves the problem, because the real issue is not a virus. The real issue is that without adequate saliva the corners of the mouth are never properly moistened, and that chronic dryness creates fissures that bacteria and yeast colonize opportunistically. Beyond the corners, look at the lip surface itself. The lips may be dry and peeling, with a thin ongoing exfoliation of skin that looks like it never fully heals no matter how much lip balm the person applies. That lip vermilion, the colored border between the lip and the surrounding facial skin, may appear reddened, inflamed, and fragile. In more advanced cases the lip surface develops a rough, slightly thickened, brownish texture as the cells pile up and keratinize over the chronically dry surface. When you glance at someone's face and see lips that look perpetually chapped with cracking at both corners and a lip surface that looks like it has never been properly hydrated a day in recent memory, you are looking at a Sjogren's mouth. Now look at the tongue. This one requires either proximity or a mirror, but it is unmistakable once you know what healthy tongue texture is supposed to look like. A healthy tongue has texture. It has small visible bumps called papillae distributed across its surface, and those papillae are what give the tongue its slightly rough, almost velvety appearance and what allows it to grip food and aid in chewing and swallowing. The tongue of someone with long-standing Sjogren's looks different. It looks smooth. Polished, almost. The papillae atrophy and flatten when there is not enough saliva to keep them healthy, producing what clinicians call atrophic glossitis, a smooth, sometimes reddened, almost shiny tongue surface. The saliva that is present in Sjogren's patients changes character as well. Instead of the thin, clear, watery saliva that healthy glands produce, Sjogren's saliva tends to be thick, stringy, and ropey. Patients describe it as feeling like cotton in their mouths. If you ask a patient to open their mouth and you can see saliva that stretches into visible threads between the tongue and the roof of the mouth rather than pooling in the floor of the mouth as a clear, thin film, you are looking at the saliva of a gland that has been significantly damaged by years of immune attack. Move from the face to the skin. Dry, fragile skin affects up to 72% of Sjogren's patients according to published clinical data, and this is not the ordinary dry skin of winter or dehydration that clears up with a good moisturizer. This is a persistent, diffuse dryness that makes the skin look thin and slightly papery regardless of the season and regardless of how faithfully the person applies lotion. The skin may look finely crepey, particularly on the forearms and the backs of the hands, and it has a texture when touched that does not rebound with normal elasticity. There is another skin finding in Sjogren's that is far more significant than simple dryness, and it is visible enough to spot when the patient is wearing shorts or a skirt. Small, reddish-purple spots, sometimes flat and sometimes slightly raised, scattered across the lower legs are called palpable purpura, and they signal something very specific. They signal that the blood vessels themselves are becoming inflamed, a process called cutaneous vasculitis. These lesions do not disappear when you press on them with your finger the way a simple bruise or rash from pressure would. They stay purple under compression because they represent actual blood that has leaked out of inflamed vessels into the surrounding skin tissue. When a Sjogren's patient comes in wearing shorts and you see those pinpoint reddish-purple clusters on their shins and lower legs, you are no longer looking at simple skin dryness. You are looking at systemic disease that has moved into the vasculature, and that changes the clinical picture significantly. Now look at the hands and fingers, and this time watch them over time rather than in a single snapshot. In approximately 1 in 5 Sjogren's patients, the small blood vessels in the fingers respond to cold temperatures or emotional stress by clamping down dramatically in a vasospastic response called Raynaud's phenomenon. The fingers turn white as blood flow cuts off, then blue as the oxygen in the remaining blood is consumed, then bright red as the vessels finally relax and blood rushes back. That triphasic color change, white to blue to red, is visible and unmistakable if you are watching for it. What gives it away in ordinary social observation is the behavioral adaptation patients develop to manage it. Watch whether someone unconsciously tucks their hands under their arms or into their pockets the moment they walk into an air-conditioned space, even when the room is a perfectly comfortable temperature for everyone else present. Watch whether they grip a cold glass of water and within seconds their fingertips start turning pale and waxy while everyone around them looks entirely normal. Watch whether they wear gloves in temperatures that no one else in the room would think requires gloves. Those behavioral compensations are the visible evidence of a problem that does not require any equipment to diagnose. You just have to be watching. In a patient who already has red, chronically irritated eyes and cracked corners on their lips, Raynaud's hands clinch the picture. You now have 3 organ systems showing signs of the same underlying immune attack. Now look at the joints, particularly the small joints of the hands, the wrists, and the ankles. Arthritis occurs in a significant portion of Sjogren's patients, and it is one of the most common complaints outside of the eyes and mouth. This is not the large, deforming joint destruction of advanced rheumatoid arthritis with its dramatic visible changes to the architecture of the fingers. Sjogren's joint involvement tends to be subtler, less destructive in the long run, but no less real in the pain and limitation it produces day to day. What you can observe is how the patient moves. Watch whether they use their palm rather than their fingers to push open a door. Watch whether they wrap both hands around a coffee cup rather than gripping the handle between their fingers. Watch whether getting up from a chair produces a momentary hesitation, a slight wince, or a careful deliberate push with flattened palms against the armrest rather than a gripping motion. These are the movement adaptations of someone whose small joints have been causing enough pain consistently that the nervous system has quietly rerouted the mechanics of ordinary daily tasks to avoid loading the fingers and wrists that hurt. The joints themselves may look normal to a casual eye or may show a modest soft tissue swelling around the knuckles and wrist that does not have the dramatic redness of a gout flare but sits there persistently, slightly warm, slightly puffy, and slightly resistant to full range of motion. When fatigue, dry eyes, cracked lips, and guarded hand movements appear together in the same person, you are looking at a constellation that points in one direction. Here is one that you observe through conversation rather than through visual inspection, and it is one of the most underappreciated signs of how far-reaching this disease actually is. Listen carefully to how someone with Sjogren speaks during a long conversation, specifically in the later part of that conversation. Sjogren's syndrome damages the nervous system in a measurable way. Research published in peer-reviewed journals confirms that the majority of Sjogren's patients experience what patients themselves call brain fog, described clinically as difficulties in memory, attention, processing speed, verbal fluency, and executive function. But the observable sign is more specific than that. It is the dry cough. Listen for a cough that never fully goes away and never sounds wet. A productive cough that brings up mucus signals an infection or a chronic inflammatory process with active secretion. The Sjogren's cough produces nothing, because the mucous membranes lining the airways are as dry as everything else. The cough sounds dry, slightly harsh, and it punctuates conversation unpredictably. Patients have often had it for so long that they barely notice it anymore. They apologize for it reflexively and call it a tickle in their throat. That tickle is dryness in the tracheobronchial mucosa. The same immune-mediated desiccation that is happening in the eyes and the mouth is happening in the airways as well, and that cough is its voice. When someone clears their throat persistently throughout a conversation, takes small sips of water frequently just to keep speaking comfortably, and occasionally produces that dry unproductive cough with no explanation of a cold or allergy, you are hearing a Sjogren's airway. Now here is the clue that lives in the dental history rather than on the surface of the body, and it is one of the most diagnostically powerful observations I make in clinical practice, even though it requires asking a single question rather than looking. Ask the person whether they have been getting cavities recently, and if so, ask them where the cavities are. In someone with healthy salivary flow, cavities form on the chewing surfaces of the teeth, in the pits and grooves where food debris accumulates and bacteria can hide from the toothbrush. That is the classic cavity that every dentist sees dozens of times every week. In Sjogren's patients, the decay follows a completely different distribution. It wraps around the neck of the tooth right at the gum line, attacking the root surface in a pattern called rampant cervical caries. The reason is mechanical. Saliva is not simply moisture. It is a complex biological fluid containing antimicrobial proteins, calcium, phosphate, and bicarbonate that continuously wash the tooth surface, neutralize the acids that bacteria produce, and remineralize early decay before it can progress. When saliva production drops to the levels seen in Sjogren's, that entire protective system fails simultaneously and the bacteria that cause decay are given an unobstructed path to the tooth surface around the clock. Patients who are meticulous brushers, who have never had significant dental problems in their lives, begin finding new cavities at every appointment. Their dentist is puzzled. The patient is devastated. And the decay is concentrated at the gum line in a pattern that experienced dentists recognize as the fingerprint of a dry mouth. If someone tells you they brush twice a day, floss regularly, and their dentist still keeps finding new cavities, especially at the base of the tooth where the root begins, you are hearing a Sjogren's story even if no one has yet given it that name. Okay. Now here is a test you can do on yourself right now, at home, without any equipment, and the answer will come back in under 60 seconds. It is called the dry cracker test, and you do not need me to provide instructions more complicated than this. Find a dry cracker. A plain rice cracker, an unsalted water cracker, a dry breadstick, anything that is completely desiccated and contains no added oil, butter, or moisture in its composition. Place a single piece in your mouth. Begin to chew it normally. Do not pick up your water glass. Do not reach for your drink. Do not prepare to wash it down with anything. Just chew it and attempt to swallow it the way healthy saliva production should allow you to do as an ordinary, effortless act. For a person with healthy, fully functioning salivary glands, a dry cracker is not an obstacle. The parotid glands respond almost instantly to the presence of food in the mouth, releasing enough saliva to soften, bind, and propel the cracker down the esophagus without any conscious effort. For a person with Sjogren's syndrome, that same cracker begins to feel like fine dust. It sticks to the roof of the mouth. It adheres to the tongue. It clumps against the insides of the cheeks. Attempting to swallow it without water produces a sensation that patients describe as trying to swallow sand, and the process requires a degree of effort and concentration that healthy people never have to dedicate to the act of eating a single cracker. If you completed that cracker test without once reaching for your glass, your salivary glands are performing as they should. If the cracker is still partially stuck to the roof of your mouth as you read these words, your glands are already telling you something you need to listen to. Pay attention to two more things in yourself after that cracker test. First, look at your tongue in the mirror. Is the surface textured and slightly rough with visible papillae, or does it look smooth, almost polished, slightly reddened, and flat? A healthy tongue has topography. A Sjogren's tongue has been sandpapered smooth by years of inadequate salivary bathing. Second, try to run your tongue across your teeth. In a person with healthy saliva production, The tooth surface feels slick and smooth because a thin film of salivary proteins coats the enamel continuously. In a person with Sjogrens, running the tongue across the teeth produces a rough, almost sticky friction that the tongue registers immediately. Dentists describe this as the teeth feeling like velvet rather than glass. You will know exactly what that distinction means the moment you try it. If multiple clues in this video matched what you see in the mirror, what you feel in your mouth, or what you recognize in the history of your joints, your teeth, your eyes, and your cough, the next step is not guessing. The next step is a specific blood test called the anti-SSA antibody panel, also known as the anti-Ro test, along with the anti-SSB or anti-La. These antibodies are present in a significant proportion of Sjogren's patients, and they are a far faster starting point than waiting for a lip biopsy appointment. Your primary care doctor can order that panel today. You do not need a specialist referral to ask for it. You do not need to wait for your next scheduled annual appointment. You do not need to minimize what you are experiencing or apologize for bringing it up. The average Sjogren's patient waits 3 years for a diagnosis because they were never given the language to describe what they were seeing in themselves clearly enough to make a doctor take action. You now have that language. Use it. Walk in and say the words. Tell your doctor you want the anti-Ro and anti-La antibody test. Tell them you want it because you watched a video that described exactly what you have been living with, and you are done waiting for someone else to connect the dots. But you do need to have seen this video and recognized yourself in it well enough to make that appointment. Check out the next video on what happens inside your body when Sjogren's goes undiagnosed for years and the damage it leaves behind.